Right. Good afternoon, everybody. Welcome to the Health and Social Care Committee. Can I have opportunity to wish you all the best for the coming year? And I know it seems like we've started the last year the same as this year, so let's hope for better times ahead. So, on today's agenda, if you look at item 6, which was the alcohol and drug service update, and if you go down to the summary 2.5, it says the National Records of Scotland are planning to release the drug-related deaths in Scotland in 2019. Well, these figures were released on Monday, so you should have a new agenda, and it'll be agenda item number 7. With your permission, I'll make that 6A, and we can take the two together because they both are they're linked. So if you're happy with that, item agenda 7 will be 6A. And we could do 6 and 6A together. Is happy with that?
Yes.
Right, thank you for that. And also, item 5, I think Alan Stevenson is going to change his recommendations. Is that right, Alan? You're still on mute, Alan.
Sorry, convener, my computer was playing up there. It's in relation to the Older People's Day service. Given what's happened in the last couple of weeks, I'll ask the committee if it's okay to change the recommendations once it's spoken.
Right, thank you. So, is there any substitutions or declarations of interest?
Convener, there is a full house. All the 11 members are here, so there's no substitutions. Are there any declarations of interest?
Yes, I'm a non-executive director of Park Lee Branching Out, and they are one of the bodies that are park funded through the council.
Thank you. Any others? No. Okay, thank you.
Thank you for that, Jim. So we'll go on to agenda item number 2. It's a revenue capital budget, and Angela Edmondson is going to speak to this. Angela?
Thank you, convener. This is the usual revenue and capital monitoring report for the period ending the 31st of October. The report is projecting a revenue overspend of 236,000, which is a reduction in the overspend reported to the last committee of 468,000. The main reason for the movement between last report and this report is due to £400,000 of costs for children and families, which we have now reviewed and identified as COVID related. So this has been removed from the projection. That is the main movement within the last report to this report. There are various overspends and underspends identified across the services. The main variances are identified at section 2.1 of the report. And there's full details available of all the underspends across the services in section 5 of the report. The report also includes estimated COVID costs of net 4.977 million. This is reported as fully funded by the Scottish Government, so therefore they have been excluded from the projected overspend of 236,000. Details of the COVID costs included within this report can be seen at section 5 as well. They're included with the other variances. To highlight section 6 of the report shows the current capital position as at the 31st of October. No slippage is being reported against the revised projection at this point. Everything is online. Information on the earmarked reserves in the report that are held by the HSEP can be found at section 7 of the report. Spend to date is in line with what we projected, and we're currently showing about 2.5% slippage against the phased budget, so we're pretty close with that. Finally, the members are the committee is asked to approve the veerment as at Appendix 6 of the report. I'm happy to take any questions that you have.
I mean, if you want to ask a question or any comment, could you use the chat, please? I have Christopher McElary. Sorry. Lynn Quinn. Lynn, you want to ask some questions?
No, I think it's Graham that wants to ask a question.
Right, sorry that. Right, Graham.
Thanks very much, convener. Yeah, getting myself and Lynn mixed up was a bit of a challenge. Come on. Yeah, it's just for a bit of clarity. 2.1 says that there's an assumption that the COVID expenditure 4.977 will be met by the Scottish Government. And obviously, the commentary that Angela gave, she said it will be met by that grant. Just give me a clarity, is it an assumption or has it been met by the Scottish Government grant?
And through your convener, the majority of the funding has actually been received to this point. So we're at a point where we're virtually almost funded by the Scottish Government. So there's hence the reason there's still an assumption it will be fully funded, but we have received quite a significant sum of money towards it.
Okay, thanks very much.
Councillor MacLeod, Jim MacLeod, do you have a question?
Well, I don't know if it's how appropriate it is to ask, convener. Whilst this is within the financial report, there are sub, headings regarding older people and the overspending. It was just, and also about learning disability. It's just one or two questions I have contained within those headings, and I wonder if it would be appropriate to ask those at this point.
If it was something to do with the financial situation, Jim, I think aye. But if it's to do with the service itself, I think probably better asking the service heads privately.
Okay, fair enough.
Anyone else get any questions on the report? No. Agree with recommendations. Item number 3 is the COVID Recovery Plan 2020 Health and Community Care Older People's Day Service, and Alan Stevenson.
Thank you, convener. As if to highlight how fast a moving picture COVID presents to us, we wrote this paper just before the lockdown occurred. And I think it was to obviously show the committee how we were trying to move into that recovery phase for older people. If I can just be clear, this report was never intended to be a service review or a service redesign. It was simply to give an update on how we were trying to move through the recovery process for older people, similarly like we've done in the Learning Disability Service, where we were able to put back a very modest level of service for those carers and service users who really their needs were critical. The thinking at the time of writing this report was we would continue along that theme and very tentatively start to think about recovery for older people services and how we use the resources that we have in relation to our day services and also the in-reach work that we're doing with people. The recommendation was going to be, as it's in the report, was in relation to us tentatively using the 2 partner agencies to look at very small numbers of people coming back into the day services while utilising the strengths of our own workforce at Hill End to continue to do the in-reach work out directly with people and supporting people in the community. Given the events of the last week or so, now part of the recommendation would obviously be changing because we need to reassess how we're going to manage older people's day services moving forward and reverting back to more of that checking out and outreach to people and making sure they're okay. It won't be a surprise to the members that many families do not want to consider at this point their mums and dads or older aunties and uncles heading into a day service. We thought we could probably test it out with very small numbers and use our staff to continue to work in outreach. But as things stand with COVID and the situation in the community with transmission, I absolutely know today we have 30 staff in the care at home service we will be shielding again, and we will really be looking to use our workforce to make sure we can keep providing our care at home service, and that is the backbone of our service. So really, it was a flavour of where our thinking was heading in relation to older people's day services, but given the fresh position we find ourselves in now, I would say to members that was the thinking 4 weeks ago, and now what we have to do is reassess that thinking, because it's highly unlikely that any of the families will really want us to be looking at bringing people into a day service. So Joyce Allen, the service manager, will be actively looking at this piece of work again, bearing in mind where we find ourselves in relation to the transmission rates. And I'm happy to take any questions, convener.
So, Alan, all the recommendations, are you want them to stand? Are you going to change them any?
Convener, the third recommendation, could I suggest we change that to, we will be looking at reassessing the entire resources we have in order to meet the needs of the people we're trying to look after. So I could agree a former words, but I probably need to look at, there's some reassessment required now, given where we find ourselves with COVID.
Okay, Vicky, what's the legal position on that being changed?
That's fine if all members agree. Can I just clarify? Is it bullet point 3 that you're amending?
Yes.
And are you amending it? From what I've taken, the recommendation is basically for members to note that the service will be reassessing how to manage outreach services during the current lockdown. Is that fair?
Day services, Vicky.
Day services. Is that a fair reflection of the amendment?
Yes.
Perhaps you could just tell the members what it is in, Vicky, before they decide on it.
Okay, so recommendation 3.1 stands, and the first 2 bullet points continue to stand. In relation to the third bullet point, I think that's deleted, and in its place, it's a recommendation for the committee to note that there will be a reassessment in respect of how to manage day services during the current lockdown.
Quite. Is members quite happy to go along with the change of recommendation? Councillor MacLeod?
Yes, I mean, I did have a question, but I think events have now overtaken us in the last few days. You know, but hopefully, once the vaccinations are rolled out to as many people as possibly can, and obviously, you know, older people will be getting looked at being vaccinated first. But hopefully, it won't be that many months more before we can see some sort of return to some sort of service, because isolation must be very, very hard, particularly for people living on their own.
Okay, Elizabeth.
Yeah, I agree with it. Yeah, I agree.
Elizabeth, you got a comment to make?
Thanks, convener. I know Councillor Jackson's got a comment as well, but mine is specifically about us making the change to the recommendations. I'm just looking at the bullet points that are asking us to look at option 2 from the 3 options presented in the paper being implemented, and I had a question about that, but I'm not sure if that still stands in relation to the change to the third bullet point that we're hopefully just about to agree, because if that still stands, then I've got a question about the recommendations generally.
Okay, I think, Alan, you want to respond to that?
Yeah, convener, thanks. Yeah, Councillor Robertson, and through yourself, convener. Yeah, I think we had a plan. The plan's fundamentally changed now, so we have to reassess completely how we're going to take this forward given lockdown, and because we know essentially that we will go down to lockdown and families won't be interested in testing out any of this work. So we really have to go back again and look now, taking account of the lockdown. And what I would suggest is families will be much more happier with us reaching out and doing that outreach to them and not exposing their mums and dads to any potential coming into the day service. And it's just not, the discussions we've had with the families are not keen to look at that at this point.
Right, let's think. Councillor Jackson, Colin.
Thanks, convener. I understand everything is in flux and changing on a day-to-day basis, but I think, convener, it's important that we recognise the hard work and dedication of the staff within Hill End, and that despite having to temporarily close down the service due to COVID, that we'll let it be known that Hill End Day Service and Respite still remains a really valued and much needed asset in providing daycare in Inverclyde. And I hope that we can still give a commitment to keeping these services in-house. And I think it's important to get that message out there, that this council really does still intend to keep these services in-house after, hopefully, we get somewhere with the COVID, with the vaccine. So that's all I want to say, convener.
Alan, be quick.
Convener, thank you. That I started the report by saying that I wasn't bringing this report with the intention of asking to look at a service redesign. So just to reassure Councillor Jackson that it was particularly only to get us through this recovery phase till we got back to services resuming again. So thank you for your comments.
Councillor McCabe, but before Councillor McCabe comes in, Louise would like to say something. Louise.
It's okay, through yourself, convener. Alan I was just going to give some reassurance. I could maybe come in at the end if that's okay after Councillor McCabe.
Okay.
Just to clarify the issue about the recommendations.
Fine, right, Councillor McCabe.
Thanks, convener. I can fully understand how the situation has now changed since the report was written, and I can obviously understand why sort of day services have been suspended and why they need to remain suspended in terms of actual physical attendance at buildings. But clearly, as is alluded to in the report, there is a significant impact on the well-being of older people. I mean, we've seen in terms of the education context that the sort of one of the national priorities around the sort of dealing with COVID has been to try and keep our schools open on the basis that obviously the well-being of our young people is paramount. And I know that young people are less prevalent, they're less sort of susceptible to suffering ill health from the virus as older people. So I understand we're not comparing like with like, but it's just to get an understanding from Alan about what sort of efforts that ourselves and our partners have been making to try and support older people through what has been an exceptionally difficult period for us all.
Thanks, yeah, through yourself. The staff have been obviously very actively working in relation to outreach. And it's been good because there has been consistency of staff, so staff know these families very well, and that's not taking account of some of the work that the third sector partners have been doing in relation to the support and the gifts, etc. But we have been working on maintaining that caring relationship, albeit from a distance, Councillor McCabe, and we'll continue to do that. The families have welcomed that in relation to that continuity of contact, but it's very, very difficult, emotionally very difficult. There is a fear factor just now, and I hope also because people are recognising that once we vaccinate people in the 70s and 80s, then people see that as the way out of this, and that's what families have been saying. Whenever the vaccination programme kicks in, there'll be a chance for us to get back to some kind of normality. So the staff have been given assurance to the families and assuring them that obviously over 80s are one of the priority groups, and that work starts next week. In fact, so we're keeping people up to date, crucially maintaining that therapeutic relationship because we know these families and we know these people very well.
Thanks, Alan.
Right, Louise.
Through yourself, convener, I wonder if we can suggest, Vicky, that we would, for 3.1, we would keep the first bullet point, and then we would take out the next two bullet points, and we would replace that with day centres, building-based day centres remain closed until we come out of the lockdown. and agree a phased introduction based on a risk assessment, and that a future report will be brought to committee.
That sounds reasonable. Everyone's quite happy with that?
Agreed.
Agreed.
Okay. So we agree with recommendations except for bullet point 2, which will be rewritten as Louise said there. Item 4 is the Children Scotland Bill 2019. Sharon.
Thank you, Convener. This report is to update committee. The reason that this report is coming to HSCP is because of its relationship to the Children's Scotland Act. And as members will know, the Children's Scotland Act and the remaining elements of the 1968 Social Work Scotland Act provide the underpinning basis for the delivery of statutory social work services to children and families. So this is an important piece of secondary legislation that addresses some of the gaps that have existed from the implementation of the 95 Act. And saying that that's not a criticism of the 95 Act, it's just a recognition that the Act is now of a considerable age. Although it still feels a relatively new piece of legislation to me. But the key issues are outlined in the paper. The bill paper addresses the key aims of the bill, and those are outlined at 2.3. What I've tried to do is to extract from the secondary legislation what the key issues will be for us in terms of the delivery of the statutory social work services. And again, these are outlined in the report. But the key issues in particular that I'd like to raise are in relation to issues about contact between and views of siblings for children who are looked after by the local authority, and a properly increased focus on contact and care arrangements between children in care, with the emphasis being on trying to ensure maintenance of contact, where possible shared placement between siblings, and also about widening the role of the people that social work would want to speak to in relation to children when they become looked after and accommodated. So that's adults in the children's wider network that we would want to be considering as part of their care plan. Another key area of provision that this report addresses is in relation to the removal of the presumption that a child can only express their views at age 12 and over. And that has now been removed and is entirely in line with UNCRC, which again is a positive addition to the 95 Act. So again, all areas that are welcomed and that really add to the provision that enables the delivery of services into the Children's Scotland Act. I would say, however, that it is, and this has been an area that has been identified and highlighted by COSLA, that the financial memorandum attached to the bill does not include additional resource for the delivery of these additional areas. So it would be appropriate for me to highlight that the added activities that will be required of social work services will be on the basis of our existing resource complement. I'm happy to take any questions.
Thank you, Sharon. Councillor Becky's got questions on 4.3 and 4.16 of the report.
Funny, thanks. Sharon's actually answered the one about the 12. Does that mean you can actually speak to younger children for their views? Or,
yeah.
Right, that's fine. And the other one is...
I didn't actually phrase that terribly well when I was speaking there, Councillor Becky. Social work always have, and the legislation doesn't prohibit it, but right. Nor does it actively require it. Whereas it's a requirement for the over 12s, it's now a requirement for all children where it is physically possible.
Good. The other one was actually about grandparents and I'm not getting into details, but I'm funny, I was asked a question on it. The rights of grandparents, because sometimes when there's a divorce or a separation and they're apart, they can't speak to each other, and the poor person in the middle, there's nothing but a football going back and forward between the mother and the father, and the poor grandparents feel their hands tied at times. So I just wonder, what rights have they got under the new Act?
The rights and responsibilities for grandparents, in my own view, were relatively well covered by the 95 Act. This piece of legislation widens the scope of that, so that it so for us, in terms of children who are looked after, it would include, and I would need to say we're yet to see the detail of the guidance that would support this, but my anticipation would be is that it will direct any person who's providing a report to the court, and you'll know that I've made reference to other professional bodies in the report, would be required to take account of a wider set of views. So in essence, rather than just relying on biological family relationships, there would be an assumption that there would be an understanding of the child's world. Now this aligns with GIRFEC, so it would be understanding the whole of the child's world and bringing to the court or to the decision-making bodies a perspective on those people's views, as well as those legal relationships that exist. And where grandparents, sometimes grandparents don't have a legal relationship, that's where it would benefit grandparents in those circumstances.
Thanks, Sharon, for that. Okay, thank you.
Anyone else got a question for Sharon? Jim McLeod?
Yeah, no, just to say, Convener, I welcome the report, and obviously any improvements that can be made is to be more welcome, and obviously giving the child more of a say is obviously is very good. I just wondered though, Sharon, you talked about grandparents there and the abilities and powers that they have now within this are more of a say that have maybe had that maybe not had in the past. Does that also go for kinship parents as well?
Again, Councillor McLeod, I think what I would say is I would think there is reasonably good provision already exists for grandparents and for kinship carers in terms of additional pieces of legislation. When I had said in my preamble that the 95 Act and the Social Work Scotland Act are the two main underpinning pieces of legislation that guide the delivery of statutory social work services, there are a plethora of others, and there's been add-ons over the years and additional secondary legislation and guidance. And that relates, your question specifically about kinship, that's an example where we've had fairly extensive additions in relation to provisions for kinship carers. I think this piece of legislation is really, in terms of this bit that you're asking a question about, is really about making sure that kinship networks, so that would be beyond the people who are directly looking after the child, so it'd be kinship networks, family and friends, neighbours and communities become part of the child's plan, so that the focusing, not in a legal sense, but in a planning sense for the child, that we're taking account of the child's whole world. And that aligns with GIRFEC, where in GIRFEC we talk about the child's world. So this piece of legislation is catching up with the policy developments around the GIRFEC arrangements.
Yeah, thanks for that, Sharon. No, I mean, I just remember some years ago, it was some years ago now, however, I had a friend who had taken on responsibilities for her granddaughter, and I know that she had a fair number of difficulties at the time, which would eventually, she was helped. But yeah, thanks for that. Thanks.
There does remain, and I would need to say there is an existing gap, and it's something that's been worked on nationally at the minute. And I'm supporting Social Work Scotland with this, Councillor McLeod, and it's around those kinship carers that fall out with the current legislation. And that continues to be an issue that we're continuing to grapple with. So that's where the kinship carer does not have a legal relationship through the other piece of legislation I was talking about. So I would imagine that in some point, perhaps during 2021, I'd like to think during 2021, we might see some further developments in that particular gap.
Okay, thank you.
Councillor Quinn, Lynn.
Yeah, thanks. I've just got a quick question from Sharon. Sharon, I was just trying to explore about the new role, which is just trying to understand how that differs from the kind of safeguarder, which you've kind of already got in place under the sort of children's hearing system. So it's just how that differs from that and who actually funds the safeguarder in it just now. Will that replace the safeguarding role? And can we access the funding there?
There'll be complementary. So the safeguarder tends to be via the children's hearing route, whereas this role is likely to be appointed by the court. So this is going to be a typical contact or residence dispute, where or in other cases where the sheriff is keen or interested to, or whoever is at the judiciary is interested to hear about the views of the child or a perspective on safeguarding the welfare of the child. This is the role that would be appointed in those circumstances. And that person, typically at today, that would be a solicitor. In the vast majority of cases, that's a solicitor that would be appointed. And what this piece of legislation does is widen the group of people who it would be at the court's disposal to appoint. So I suppose it's widening the skill set and the range of different people that would be available to join what will be a list of people with all of the usual safeguards and all of the usual. So people will have to be appropriately qualified, be appropriately supported and meet requirements for the delivery of these reports to the court. So that would be the main difference, and it would be separate from the arrangements in relation to the safeguarding. And in relation to the money, and I don't know if Angela will remember, Angela had done some work on the financial memorandum for me. I can't remember how it was proposed that those arrangements would be paid, but in current arrangements, these costs are met either by the people bringing the action or by legal aid arrangements. So in the current environment, there's no cost to local authority for these. By and large, there's no cost to local authority. Angela, was there anything from the financial memorandum that stuck out and that could...
It's not, Sharon, sorry. There's nothing standing out for me. But anything, if you wish me to share any of that information through the review I did, I'm quite happy to do that.
Thank you, Sharon. Is that all right, Lynn?
Yeah, great, thanks.
Right, the recommendations is to note the changes to the legislation and also note the consequence of resource implications. Agree with the recommendations, note the recommendations, to agree?
Agreed.
Thank you. Agenda item number 5 is the Greater Glasgow Clyde briefing on Inverclyde Royal Hospital. And this was a paper the committee asked for, and this is the response. It's been presented today with Alan Stevenson. Alan.
Convener, thank you. Through yourself, obviously this has been a briefing put together by our acute colleagues at Greater Glasgow and Clyde Health Board. I've tried to summarise some of the main points in relation to the report. Clearly it's not a service that I'm responsible for or operate in any way, so I've just really tried to bring forward some of the main points with the recommendation to note the content. So hopefully I've managed to do that, to bring out some of the salient points, but the briefing itself stands alone as a standalone briefing from our colleagues in the acute services. Thank you.
Thank you. I've got a list of names here. The first one is Jerry Doreen.
Thank you, Convener. I was just to remind everybody that Alan is an officer of the council and is delivering a paper originated by the Health Board. He does not have any policy input relating to the hospital. It's an acute issue.
Thank you, that, Jim. Right, the next person who wants to speak is Chana. Chana.
Thanks, Convener. It's regarding 2.5, and I'm looking at the figures, and this is one of the things we brought up at the other boards. They're telling us about the people that get sent up to Elizabeth University Hospital, and it tells you that we have, where is it? Hospital, being one of the 4 established national IRH, continue to treat the majority of trauma patients, but will see 1% of most critical cases transferred to Queen Elizabeth, and 14 patients per week transferred to Royal Alexandra, with 60% of them transferred back. Why is that? Seriously, I can see, forget Queen Elizabeth, because that's the big hospital and there's people up there. But why is it we're sending people up when our place used to have a lot more beds and a lot more stuff for it to deal with us, and now we're sending it closer to Queen Elizabeth, which means instead of them come down a way, which they could do, we're going up. Now, that is, to me, is wrong, and we've asked for this before, and that's part of the reason, because they keep taking things away and they don't tell you exactly what it is and why everything gets moved the one way. I just find that awful, because people can travel down here, and if it's, or they can travel from Paisley, they can travel to Queen Elizabeth, or they can travel to Greenock, and we cover an area, and it mentions in the area Isle of Bute and Cowell Peninsula. It forgot in Ayrshire, North Ayrshire, but it forgot to tell you the islands we deal with. And I think, if I'm not mistaken, there's 27 or 29 islands on the west coast. We deal with the people on there. Surely, God, we should be one of the main things that's going, and we can get them into a helicopter fast enough and land at a battery park and up to the hospital. And that's not along, and that's happened before, and it'll happen again if need be. Now that's it. The other thing that surprised me is in the renal unit, Convener, because they're telling us that they can't deal with everything in the renal unit, and yet at the same time, that many abseiling down that hospital to raise money to make sure it was up to a standard that they wanted. Now, I want to know if they've moved stuff out of there because it might have needed replaced, but surely we should have known that, because we've got people down here who've got problems with kidneys, and with this virus just now, a lot of the problems are kidney related. Again, no information and lack of knowledge coming through, and we're left with a building we don't know what's happening in. And they come up and tell you that. Surely to God, it's about time they told the people in Inverclyde exactly what they're doing and everything else, and all the different stuff right through it. I just find that when I read this, I get angry and wonder what was going on, more so when I know a lot of the people who actually went down there to raise that money, doing the abseiling and various other things within the area to make sure that we looked after people with kidney problems and got all the equipment. And it wasn't pennies, it was quite a lot of money that was raised in this area by various groups. And that's it. So that's my big one, is how can they say that's 1%? How can they do these things? And how can they tell us that we've turned around and got a good trauma unit when they've cut it down? I think it's 2 beds. 2 beds is what they've got. And it used to be 9. It was 3 banks and 3 was 9. So I just find that they might tell some people, but unfortunately I've got facts and figures. And to turn around and find out with the mental health one, I have seen papers that tells you the best thing you can do for anybody with a mental health problem is to make sure that they're in an environment that they feel safe in and everything else. And the worst thing to do is transfer them out their own town. In some cases, you may have no other option, but in other cases that hit. They now are talking about doing with the police and getting the police to do it. The police are taking all their time to try to catch criminals just now because of the shortage of police officers. what chance have we got of getting them and helping? And I'm not saying they don't do it. Helping with someone going out to attend, along with a nurse who's capable of doing that, to look after somebody with a mental health problem, who might be violent, might not be violent. But surely, God, we've got to try and get that all sorted out so we can work together, but we've got to make sure that we have proper people looking after people with mental health. It's absolutely crazy to say, oh, you can send them up the road and do that at night time and do this. Everyone's going up the road. Why didn't we all look and say, we've got to do this here? Seriously do here. And how much does it cost for an ambulance going up the road? I don't know. But tell me it's £300 if you turn around and get one in just locally called out. That's the sort of things we've got to look at. How we can spend money to make sure that people are service. Thanks, convener.
Thank Karen. I think there was a lot of question put in there, Chana, and Alan Stevenson did say it. He was only presenting this paper, and obviously he's not in a position to answer most of it. But before I start this item, Councillor Chris McLeary had sent me a mail right at the start on the chat. He wanted to ask 2 questions, and I'm sorry, Christopher, for missing that out, but the chat is full at the moment, so I'm going to let Christopher McElhinney come in at this juncture. Christopher.
Thanks, convener. That'll save me having to tell my mum on you. I've taken cognizance of what Councillor Dorian said, but hopefully if there's questions that are for the Health Board to answer, Alan would be able to put questions to the Health Board and then circulate them back to the committee. And the first point I wanted to raise was on chapter 7, page 37. So it's obviously in relation to the ICU care. So my main concern is that the Health Boards still haven't established whether this was indeed a clinical decision, or, which I think is, they've taken a quantitative approach to things. So I was wondering if you would be able to liaise with the Health Board to ask them what the cost per patient treated in level 3 was before they adopted the new pathway, and what the cost now per patient is, per level 3 treatment is in the new pathway. Because it'd be good to see, because obviously they keep those figures. So if it is the case that there's not much of a difference in cost, then the argument that perhaps this was a quantitative approach is nil and void. But if it's the case that it seems that the new pathway is substantially cheaper, I think there is a real question to be asked of the Health Board, that would suggest they've taken a decision on, which they've said is a clinical decision, but ultimately it's a cost decision. And you just had to look to last night to see where the concerns were. People were turned away from the University Hospital in Glasgow because it was full. So it'd be good to know what would have been the situation last night for someone from Inverclyde that required ICU. Would they have been transported via ambulance from Inverclyde Royal to Glasgow to be turned away and diverted to another hospital, or even worse still, ironically, sent back to Inverclyde to establish an ICU facility? So it'd be good to get clarity on that. The next point's on, Councillor Rebecca touched on it, but I'm quite confused with the numbers. So I feel the Health Board are truthful when you ask them the right questions. I just genuinely don't think they volunteer information to us. So if you look at the Major Trauma Network section, page 40, which of course has been in Health Board minutes and meetings, but none of us are members of the Health Board, so there shouldn't be an assumption that we read all the papers of the Health Board. And indeed, some of this data wasn't in those papers for those of us that had read them. But earlier on in the year, of course, I had the privilege, I got to meet the Health Secretary, who was briefed by the Health Board, and the Health Board met us. They didn't volunteer in tandem with, oh, this only impacts on X amount of patients, ICU. They didn't volunteer the other information in terms of, well, as of March 2021, this is a new trauma pathway. And the numbers to me are concerning. So 1 patient a week, 52, will be transferred out of Inverclyde to Glasgow. 14 patients a week, or 728, will be transferred out of Inverclyde to the Royal Alexandria. That's including the 100 ICU patients, which was spun as only a 7%. That's 828 patients a year will be transferred out of Inverclyde Royal Hospital onto other hospitals to get treatment that previously was delivered in Inverclyde. And the reason I suppose the trauma one's so concerning is The report says that there are 6,000 seriously injured patients a year. So that's 6,000. The Inverclyde share of the population, if you take the population that IRH serves of 125,000 people, that should mean there should be about 2.5% of seriously injured patients get treated in the IRH locality. But that 728 of the 6,000 equates to 12% of all Scotland's seriously injured patients. So I don't see how that can be accurate, because unless we're saying that you're 5 or 6 times more likely to suffer a serious injury if you live in the locality of the IRH. So it'd be quite interesting to delve into those figures. And just to clarify, because I see some officers were taking notes, it says at the start of the chapter there are 6,000 seriously injured patients in Scotland each year. So that's 6,000, which is obviously you can work that out as a percentage. And then it says that there will be 14 patients transferred to RH, 1 patient transferred to the Queen Elizabeth. So that's 728 patients. So that to me jumps out that you've got I just don't see that as being credible, that you're 5 times more likely to, between 5 and 6 times more likely to suffer a serious injury living in the Inverclyde Royal Hospital locality than you are in the Scottish average. But I suppose that's just a data question. The main issue there, of course, is the fact that you've got 828 patients a year being transferred from Inverclyde Royal Hospital to other hospitals at the other end of the M8, the Glasgow side of the M8, sorry. Whereas when we had a briefing and the senior clinicians and officials from the Health Board come to meet us, it's only 7%, it's only 7%, it's only a minority of patients. That number's not an insignificant number. That's 828 ambulance trips from Inverclyde up the road and vice versa. That's 828 times that anaesthetists, nurses, etc. will be taken out of our hospital over the course of the year. That to me is quite disgraceful. And I know we've challenged the Health Board, but I think the challenge has to continue. COVID, obviously, at the moment is the overarching issue. The pathway is stated benefits 30% of patients that need renal support, but I don't think this is sustainable in a post-COVID world that we accept these numbers. So it'd be good just to round up for Alan, because I think maybe you would need to put these to the Health Board. If you could get us the cost comparison between how much it used to cost to treat a patient that needed level 3 support in Inverclyde Royal Hospital versus how much it now costs with the new pathway, so we can compare the difference. And if you could delve into those figures for me, which don't seem to add up in terms of the proportion of seriously ill patients, because if this report's correct, it would be quite appalling that if you were to say you've got a 5 times more likely chance of being a seriously ill patient that's served from the Inverclyde Royal Hospital than anywhere else in Scotland, but we're not going to provide that care in Inverclyde Royal Hospital. You think that's an argument for that care to be provided in Inverclyde Royal Hospital, not for you to be transferred to the Royal Alexandria Hospital or the Queen Elizabeth University Hospital. So it'd be good if we could maybe just circulate those responses if we ever get them back.
Thanks for that. I think there's a lot of questions there and a lot answered, Didi. But before any officer wants to respond, I think Councillor McCabe has been waiting quite well. So I'm going to ask Councillor McCabe to put his point of view across at the moment. Councillor McCabe.
Yeah. Thanks, convener. I've got quite a number of questions on the briefing paper, but Alan can relax because I'm not going to ask the questions. I mean, I think it's important we understand the background to this paper, which was, given the concerns over the changes to the intensive care unit, we saw a meeting with the Health Board and we had an all-members engagement. Following on from that, a number of us met politically from each of the political groups to discuss how we might sort of take forward our concerns. And it was agreed that I would request a briefing paper to come before this committee, which would then allow us the opportunity to consider how we might take forward the engagement, which isn't about simply asking questions here and officers going away and getting the replies and coming back. So my proposal is that, and I have discussed this obviously with political colleagues, that we do establish a cross-party members working group, supported obviously by officers, on local hospital services, chaired by the convener with a representative from each of the political groups. And the working group would meet and review this particular briefing paper and look at what sort of issues that we want to raise with the Health Board, what questions we've got, with the purpose obviously trying to sort of seek assurances on the future of local health services and ensuring that they will be sustainable. And then at some point in the future, the working group would report back to the committee. Part of the process would obviously be engagement with the Health Board, both at a senior officer level, but directly with the chair of the board as well. Because there are quite a number of questions in here, and the briefing paper is helpful, but it doesn't give me certainly the reassurance that I'm looking for around the sustainability of local health services. So I think it is important that we have that engagement, but it needs to take place in a sort of proper forum. And I think, as we have in the past established working groups around health, I think it's important we do establish another one. Now, I'm conscious of the fact that we are in the middle of a global pandemic. We're in the middle of a health emergency, and the focus, as Chris says rightly, has to be on dealing with a pandemic. And it may well be that it will be a while before we can get the working group established or meeting. It can be a while before we engage with the Health Board, but the future of our local hospital services is not going away. It's the sort of long term that we need to look at, as well as obviously the more immediate concerns. So that certainly would be my proposal, that we establish a cross-party member working group chaired by yourself, convener, with a representative from each of the political groups, supported by officers, to engage with the Health Board with a view to ensuring that we are assured by the Health Board that they are going to deliver sustainable quality health services for the local population going forward.
Thank you. What would we digest Stephen's proposal? I have a list of people who want to speak. It's Graham, Lynn and Elizabeth. So Graham.
Thanks very much, convener. Further to what Councillor McElhenney and Doring had said regarding the paper, and then obviously Councillor McCabe has just clarified, because in communication with the our corporate director, with Louise, she's quite clearly said, I had asked, can we not have the board here? And she's established that it's not appropriate for Greater Glasgow and Clyde to be here to answer questions because they don't answer to us. So Councillor McCabe has sort of taken that forward unwittingly, because I wanted to know, how do we, apart from individuals writing to the board, how do we? So a working group would obviously answer that question. It was really a comment rather than a question. So fully supportive behind that, and the sooner we can get it up and running, COVID accepted, the better. I did have one question. I don't know if Alan, I don't think Alan can answer, but maybe Louise can. 3.2 of the paper, or the front page of the paper, talks about specialist services being delivered, and you have to move Inverclyde citizens exactly to those special services across the board. We may not like that, but we understand that the board equals Greater Glasgow and Clyde Health Board, and you may have to move to find a special service. But the paper goes on to say, or the west of Scotland. So my question then is, does that mean that potentially that the plan is that we have to move to Ayrshire and Arran Health Board for a special service, or we have to move to the Highlands Health Board for a special service? Why was the words west of Scotland added in to 2.3?
Louise, if you want to reply to that, if you can.
To yourself, convener. I never wrote the report, so I can't be absolute in relation to Councillor Brooks, but I would assume it's because Greater Glasgow and Clyde usually is the specialist service, so it's a specialist service in relation to trauma. It's North Ayrshire and Argyll that tend to use Glasgow, not the other way around. It's not that services would be moving out of Glasgow. But there may well be other centralised services. I'm trying to think of something. I can't think of anything off the top of my head, but there may well be something in relation to gender identity, or there could be something in Scotland that is so specialised and it's so few people that it's delivered from a central place. So it may well be that, but I'm making assumptions and I can clarify if that's helpful.
No, thanks very much. And I understand that the process is not the best here, but maybe the working group would actually get that clarified eventually when the working group comes together. Councillor McCabe.
Thank you. Lynn Quinn.
Yeah, really, I'll just make it quick. I think it's just to echo the points made. I think it's great that we've now got information. Obviously, that then spurs lots of other questions, but it's a good first step that we actually have this paper in front of us with information that we can go back and then challenge. So I'm really supportive of any forum that we can then have a discussion with the Health Board. The only thing that I would mention that's probably quite immediate is, there's a section there under page 39 about investors in people. I've got serious concerns about the health and well-being of the staff at Inverclyde Royal Hospital. So anything that can be done in the immediate term to safeguard that would be much welcome. I'm not sure if the Health Board are aware of how bad it is, how low morale is, and the issues that we've got up there from our staff. I'm talking about the staff because they are our constituents. They're people that we need to represent as individuals rather than just a health board. So I really just want to put on record that I am concerned about some of the staff up there and the support they're getting.
Thank you, Lynn. I think we all share your concerns regarding the staff. They're doing a fantastic job in Inverclyde Royal and, of course, all the health service. Elizabeth Robertson.
Thanks, convener. I had a comment and a question. I'm absolutely happy to leave my questions for the sort of working group and the progress of that. I think Councillor McCabe's suggestion is a sensible one and is the kind of natural progress on from what we had asked from this, that we would have a briefing from the Health Board so that we could then use it as a springboard for further discussion. So we're at a natural point in progressing what we had hoped would happen anyway. I think that it's good that we have the briefing, as has been said before, but I think it probably does, the further we dig in, the more questions there actually are. So I think the proposed course of action that's been brought forward by Councillor McCabe is absolutely the way to go.
Thank you. I remember, Jim.
Yes, thanks, convener. I'm on board with what much people have said already. I think having the report which was requested is good, and it gives us some background. It gives us up to date what is going on and what services are being delivered in Inverclyde Royal Hospital. I still don't think it in any way answers any of the great concerns that a lot of us have about services, and particularly what the driver has been around this, which is about the intensive care unit. I think I mentioned in the past I was in intensive care myself 5 years ago, and thank God it was there. I don't know what would have happened if it hadn't been, that's the fear. I mean, Jan was said earlier on there used to be many more ICU beds. Now there are only 2 beds, with a proposal that 1% is going to the Queen Elizabeth University Hospital in Glasgow and a further 14 to RAH. It does throw into question, what could be the future for the 2 beds that we still have. What could it be a greater impact on or a threat to those ICU beds? And if that happened, then what about any operations getting done at Inverclyde Royal? Because if you're having any sort of major surgery, then you need an ICU in case of any complications. And of course, that is always a danger in any operation, that people might have to get treated in an ICU setting. But it's also a bit of impact. I worry about the impact and the effect that this could have, which we still are no clearer on. On staffing levels, we've seen a number of services over the last 16, 17, 18 years gone from Inverclyde Royal Hospital. We've seen struggles to get junior doctors, we're told, because junior doctors won't come because there's less disciplines for them to learn off them. And if we were, God forbid, we were to lose ICU, then that's yet another service. It might be even more difficult to attract doctors or consultants. And it's also impact on staffing levels. And, they're crucial in the big scheme of things. We can't under stress the importance of our staff. Of course it is, absolutely. In the past we've been told that, of course, there are specialisms. So if you've got heart-related problems and you need a heart operation or a bypass or whatever, you go to the Jubilee. If it's cancer, you go to Beatson. If it's a neurological problem, you go to Queen Elizabeth in Glasgow, and that's that's part of life now. But as further removal of some of the service which has been going on for a long time, the ICU, is it really necessary? Is it really necessary at this time during the pandemic as well? So there's a lot of questions here. I think Stephen's proposal for a working group is a way forward. It's funny because myself and Elizabeth were just talking the other day there about a working group taking this forward, and Stephen's came out with it today. I think that's certainly a way forward to try to address these issues.
Thank you, Jim. Well, Tana.
Regarding meeting the board, we the last time when we had working group met with Sir John Arbuthnot, and the other one was Robert Calder, who used to work down here. He was chairman of the board, and they met with us. So I don't see why suddenly they're saying they can't meet with us regarding this. We're trying to resolve a problem that they've got and we've got, and how best we can do it. And it's about time we did stop Big Brother stuff and start acting as if we are working together for the benefit of people's health. Thanks.
Thank you. Anyone else got a comment to make?
Could I just come in on that point, Jana made, convener?
Yes.
The health board aren't saying that they're not prepared to meet with us, Jana. We've no asked for a meeting with the chief executive and the chair of the board, but that's something I think that the working group will want to do. We obviously met with senior officials in terms of the briefing on the ICU, but I'm absolutely sure the working group will want to meet with the chair of the board and the chief executive as part of any engagement. And I would be very surprised if the chair and the chief executive weren't prepared to meet with us at an appropriate point.
Yep. Obviously, sorry, I understand there was a one meeting there, convener. I'm quite happy, and as I said, I found them very accommodating to turn around and meet with us to try and resolve it. But if they're of a mind of not meeting us, then I think that's wrong.
Thank you. Right, everyone, we do have a proposal for Councillor McCabe, but we set up a cross-party, all members working group, chaired by the convener, to contact the health board and ask for dialogue, I suppose, or a meeting with them. Is that quite correct? Is that quite correct, Vicky?
Yes, convener, it was to establish a cross-party members working group on local hospital services, chaired by the convener with representatives from each of the political groups to consider and supported by officers to engage with the health board and consider the briefing note, etc.
Thank you. Does everyone agree with that proposal?
Agree.
Right, thank you for that.
A representative from the independents as well, because of course they're not a political group.
Councillor McElhinney is quite right. I should have qualified my proposal by saying it was political groups and partnerships as well. But you're quite right, Councillor McElhinney. But the spirit is the intention would come from each of the political groupings or groupings.
I think that's clarified that, Chris. Right, okay, so we're happy with the proposal. Everyone happy enough? Right, okay. We go on to item number 6. When this report was made, it was a month before the Christmas, as you well know. And on the summary 2.5, the Director of Scotland are planning to release drug-related deaths in Scotland in 2019 on the 15th of December. These numbers have been released to us. They get released to us earlier on this week, and we got another agenda item, which would have been number 7. With your permission, I said before the meeting, I'm quite happy to take these 2 items as 6 and 6A because they're interlinked. And if you're happy with that, we can do that. Everybody quite happy with taking the 2 as a 1? Thank you. Right, it's going to be presented with Anne Malaki. Anne?
Hi there. Can you hear me okay? I'm having some difficulties. That's why my camera's off.
You can hear me all right.
Right, great. So I will talk to the Alcohol and Drug Recovery Service paper, and then Andrina will talk to the drug-related death. So I'll go through the points that I wanted to raise about the BDRS paper. So the committee members have requested that the service provide a regular update. The October report combined the activity of the Alcohol and Drug Partnership and the work of the Alcohol and Drug Recovery Service. That report also gave performance information on the Alcohol and Drug Recovery Service. The same information is included in Appendix 1, and the reason that it's the same information is because the next quarter wasn't available as yet. So that's why we've not included it in the full body of the report, but as an appendix. So the aim of this report is to give an update on the detail of how the Alcohol and Drug Recovery Service redesign work is being taken forward. The redesign requires significant change to the way that the team works. You'll know that the review was in progress prior to COVID pandemic and was put on hold by NHS Greater Glasgow and Clyde. An agreement was agreed to progress this in October last year. It's fair to say that the pandemic has had a significant impact on taking the work forward of the review of the Alcohol and Drug Recovery Service. We require a process of engagement with staff and staff partnership, and it's required to make changes to job descriptions, the pathways within the service, and the expansion of the treatment options. The treatment options that we're hoping to expand are both pharmacological and non-pharmacological treatments, and it requires some processes around governance arrangements, to be developed and embedded within the team, and that's to ensure that the service user safety and monitor effectiveness of the service delivery. As stated, I can't emphasise the impact the pandemic has had in taking this work forward. There are a number of changes that have already been taken and increases support within the community, and they're noted in section 4 of the report. Section 4.13 describes how the steering group structure is going to be developed to take the work forward and what the work groups and the arrangements around that are. In 4.2 of the report, you'll note that the review of the prevention and eradication work is going to be led by the Inclusive Culture and Communities Directorate. They will report directly to the Alcohol Partnership. But the report proposes that the 2 posts that sat within the Alcohol Drug Recovery Service move to the Community Learning and Development team, and that's to support the wider prevention agenda. And that will be subject to engagement with staff and staff partnership, because there are changes or there are HR work that needs to be done to take that piece of work. The committee is asked to approve this transfer of staff and the associated budget pending further discussion with the individuals, as I previously mentioned. The committee is asked to note and comment on the content of the report, and we're suggesting for the next Health and Social Care Committee that we focus on measurement outcomes and perhaps on the new National Drug and Alcohol Information System, DAISY, implemented in April 2012. So maybe take questions after Andrina's presented the drug-related death paper. And I suppose it's fair to say to introduce that paper, if we were talking about one drug-related death alone, that would be a tragedy. Every death impacts on the wider Inverclyde community, as each person is someone's child, sibling, parent, wider family member. And it's difficult to fully understand the impact of deaths across such a small community. And I suppose we need to be mindful of the impact that COVID might have had on the subsequent figures. Andrea's going to talk through the content of the report and the work that's been done locally to address some of the issues, and then we'll open both papers up for questions, if that's okay.
That'd be fine, Anne.
Thank you.
Andrea.
Councillor Moran, we might have lost Andrea. I've just texted her, she's having problems getting back. We maybe want to take some questions now, if that's okay, through yourself, convener, on the service element. And then
they'll get questions on 6B, but I've got a bit for you, a question on 6A.
I do. I've got two on 6A. Come back to later for 6B. Right, so I think it's a really good move that we're having this sort of move towards CLD in terms of prevention and education. I think that makes complete and utter sense. But I was just wondering why we've limited it to prevention and education and not articulated any involvement of CLD in the recovery phase, because that seemed to make sense to me as well, is my first question. And secondly, Louise has said a number of times that the work that's done in terms of what we're doing for alcohol and drugs at a council level works, but we maybe are not getting the sort of changes in the metrics that we want to see, and that's maybe a wider issue. And I'm just wondering what this paper and the next paper, what the role of the Alliance in having a look at these would be.
Louise, you want to come in since we're a technical problem with your two staff?
Through yourself, convener. CLD are involved. There's a subgroup in relation to recovery, Councillor Robertson, and then on the subgroup, and there will be opportunities, particularly in relation to adults, education, volunteering, which will involve CLD. And I suppose I would be hoping that we would take a paper. I will certainly be taking a paper and an update in relation to the Alliance Board in relation to alcohol and drugs. Primarily, the catalyst being drug deaths, but we're due to take a report back anyway, and the ADP annual report is there. That may be hindered by some of the kind of progresses of the things we wanted to do, but we'll certainly be taking a report to the Alliance.
Councillor McCabe, you got a question on 6A?
Well, it spans the both of them, to be perfectly honest, convener. And I suppose I don't really need to hear Andrea present 6B without comment. I mean, the reality in terms of the drug death statistics that are the subject of 6B is that there was a huge reaction to them at a national level, so much so that the First Minister sacked her Minister for Public Health, who had responsibility for politically leading the national drug strategy. She has said that she will attend the next meeting of the National Strategy Group. She's accepted that her government has failed, basically, in terms of tackling the issue of drug death, where we've seen sustained increases in drugs death. And those sustained increases are obviously reflected at a local level, and we are an area where we have the third highest rate of drugs deaths in Scotland, with Glasgow and Dundee ahead of us. And it's no coincidence that Glasgow, Dundee and Inverclyde, three of the most deprived local authority areas in Scotland, are unfortunately top of this particular league. So clearly the strategy at a national level hasn't been working. And I think we need to be honest and say that the strategy at a local level hasn't been working. And a review of our services, which obviously has been undertaken and is ongoing, I would say is a reflection of that. Clearly, we as a committee don't have the lead responsibility in terms of the strategy, as the corporate director has reminded me. there is a drug and alcohol partnership which feeds into the Alliance board, and absolutely when we next meet as an Alliance we will be discussing these particular challenges. But there is clearly a big interest from local elected members in this particular issue, and obviously the wider community as well. And I think it would be beneficial, accepting again the difficult circumstances we are in, that at some point, and when it's appropriate, that we do have an all members briefing around the actual alcohol and drug strategy, and what we are doing to address these underlying challenges, particularly obviously around drugs deaths, because we simply can't go on as we are. There needs to be radical change. I'm expecting, on the back of the First Minister's personal intervention in this particular matter, that we're going to see radical change at a national level, and hopefully significant more resources which will flow through to the local level, which will help us locally address the very serious problems we've had. But we really need to wake up here and reflect on these pretty awful statistics. And they aren't just statistics. They're individuals, they're people who are born and brought up in our communities. They're families whose lives have been devastated by these deaths. And we simply cannot continue to just each year throw our hands up in horror and continue as we're doing. There needs to be radical change that means that we reverse this trend. I don't have the answer to that as a mere politician, but surely the collective brain power of the Scottish estate can find a way that we end up changing this trend. For Scotland to have not only the worst drug death statistics in the United Kingdom, but the worst drug death statistics in the whole of the Europe, brings shame on us as a society.
Thanks, Steve. Is Andrea Hunter with us yet? Andrea?
Yeah. Can you hear me?
We can hear you now. Andrea?
Can you hear me? Right.
Yes.
I'll leave my camera on.
Right, okay. There's a load of questions, so what I'll do, I'm going to hold back the questions until you present the second part of the report, and then we'll hold up the questions. Right, Andrea, on you go.
Okay, thank you, Convener, and apologies for losing connection just at the vital moment there. So this paper provides information relating to the National Records of Scotland report into the 2019 drug deaths. I think members are aware it was a delayed report from the National Records due to issues with toxicology for a number of cases. So data has been made available at a national level, with some analysis being done at a health board and a local authority level. And what I'm keen to do is take you through some of the information. I am conscious that the report contains a lot of data, and however, as Councillor McCabe has just pointed out, behind each and every one of these figures is a person who's sadly lost their life. So it's just remembering that in the background when I'm talking about figures and data. So as members will already be aware, at a national level, year on year, there has been an increase in drug deaths, with 1,264 deaths in 2019, which was a national increase of 6.5 from 2018. Looking nationally, males account for 69% of all deaths, and over time, as shown in figure 1 of the report, the median age has increased from 28 years up to 42 years of age at time of death. In terms of substances which are implicated or potentially contributed to the cause of death, there are 4 key groups, which broadly speaking can be split into opiates, which includes heroin, morphine, methadone, benzodiazepines, and I think it's important to note that that is both prescribed and what we class as benzodiazepines, gabapentinoids and cocaine. So nationally, heroin, morphine, street benzodiazepines, gabapentin and cocaine have all increased. There has been a decrease in prescribable benzodiazepines, and methadone found in drug deaths was similar to previous years. I think what is of note is that a key finding is that 94% of all deaths have involved more than one substance, and further information from NHS GGC data shows that 3 or more drugs were common in cause of death. So polydrug use has become a much bigger issue. And I think that's reflected in figure 2, which shows that in 2013, 28% of deaths involved only one drug. And actually now, when we look at 2019 figures, only 5.7% of deaths have only one drug involved. And similarly, in terms of 4 or more drugs, this has risen from 4.3 up to nearly 20% of all deaths. So polydrug use is a changing picture as we've gone on. We'll also see from the information that overall health is poor in this group, and more than 25% of those who died have also had an underlying health condition such as COPD, heart disease, and obviously that is closely linked to the ageing profile, which I mentioned earlier, but also linked to just general poor health across this the population. We know that they may not seek treatment, they may not access GP treatment, primary care treatment, etc., as much as the wider population. If I can turn now to the Inverclyde data, I think we need to take care when we're discussing this because the numbers are small. So we just need to be reminded of that. And as members are aware, there were sadly 33 drug deaths in 2019, which for Inverclyde was an increase of 37.5% from 2018, when there was 24 drug-related deaths. Just to remind members, in 2017 there were 23 deaths, and actually when the data came out in 2018, Inverclyde had only seen an increase in one, which, although we do not want to see any increase, it was much smaller than what other areas in Scotland saw. However, unfortunately, we're clearly seeing that increase now between 2018 and 2019. As numbers of actual drug deaths go, the numbers vary across Scotland, as it can be seen in figure 3. So using the 5-year rolling average per 100,000 population is a much more it's a much better kind of way of looking at the figures. But unfortunately for Inverclyde, that does show us third after Dundee and Glasgow for deaths. In terms of the analysis that we have been able to do within Inverclyde, we have 79% of our deaths have been males, the remainder females, and that's compared to 69% nationally and also in GGC, so a slight difference there. An increase in deaths involving heroin and morphine, which is similar to the national picture, a decrease in methadone being found in the drug death. Benzodiazepines were the most common drug found, with street benzodiazepines found in all deaths, which involve benzodiazepines, and that's an increase. There was a slight decrease in deaths involving alcohol to 15%. However, for Inverclyde, that's still higher than the GGC data, which was 9.9% for alcohol being involved. And there was a slight increase in cocaine being implicated. We will be doing further analysis of the Inverclyde data, which will be undertaken by the drug death analyst. And we will look to share some of this data. Now, some of that future data will help us look at each individual case and help us identify whether there's any kind of trigger points that we know, for example, somebody released from prison within a short period of time before their death, which we know may be a trigger point, and we work hard to try and get seamless pathways. But again, we need to use some of this for learning. If I can now turn to the actions that we're currently undertaking, and as members know, the responsibility and the remit for this does sit with Inverclyde Alcohol and Drug Partnership, which has got the range of partners that you would expect to see involved. And it has a current strategy based on the national strategies focusing on the cross-cutting themes. 5.2 in your report shows the complexity involved in this because it's not straightforward and there's no real simple answers to this. And it sets out, I think, quite helpfully the individual and the societal drivers, which are really wide-ranging. But we do have to note that trauma, deprivation and stigma are really key here. And I think particularly the focus on stigma is coming through both nationally and locally as an area that we need to target. Appendix 1 sets out the actual ADP drug death prevention plan that we've currently got, which is focused on the 6 key areas as directed by the National Drug Death Task Force, focusing on the areas of increasing naloxone distribution, making sure that we've got immediate response pathways for non-fatal overdoses, medication-assisted treatment, targeting people most at risk, public health surveillance, and equity of support for people in the criminal justice system. We have reported to committee previously around some of this work. However, I think it is important to note that the plan provides an update against the range of actions, which include increasing naloxone distribution. It also includes changes to the medication-assisted treatments, and new medications are coming on board all the time. So, for example, Buvidal, which is now a longer acting injection, which can be given, which can last a week or a month, and we're starting to use that with some of our patients. Buprenorphine treatment is also coming on board, and that's in the form of patches and injections, and also a waiver format that can go under the tongue and dissolve. So there are new treatments coming on board, and all of them will help, particularly with some of the stigma that's involved in people having to go on a daily basis to the pharmacist to be prescribed medication. We are reviewing all deaths, and we've set up a drug death review group to look at what learning we can have around that, and that's now involving the police and colleagues across homelessness, community justice, the prison healthcare where appropriate. And we're also reviewing evidence from other models across Scotland to see what could we bring to Inverclyde, and some of those may be fairly radical, but I think Councillor McCabe pointed out earlier on that with the number of drug deaths nationally, we probably do need to consider more radical programmes of work. So in terms of the drug death prevention plan, we are currently reviewing it, and we've actually got some sessions planned for next month with the Scottish Drugs Forum to review our current plan in line with the Staying Alive in Scotland framework, to really kind of challenge ourselves to make sure that we are taking all actions that we can do, and we'll be developing a revised action plan. So I will stop there. I'm conscious there's a lot of information in the report, and I'm conscious that there will be a lot of questions, and I'll try and do my best to answer those.
Thank you, Gina. I'm going to refer back to the people asked question first, and at 4:06, Councillor Doreen asked one, Councillor Graham Brooks at 4:09, Councillor Jackson and Councillor Rebecca. So in that order, could you please ask the questions, Jerry?
The number of deaths related to drugs made Scotland #1 in Europe. Within that, Inverclyde is third in Scotland, with again an increase from 2018 of 9. The rollout of naloxone may assist in reducing the overall numbers to ambulance crews and police on a trial basis. I spoke to my son-in-law, who's actually a policeman in Johnston, and I thought I had been led to believe before that the trial was going to be commenced there, but he has said that this is not true. It is in Glasgow Central that it is being done. I welcome the introduction of the different modes of medication, and I'm sure that this will help. But what is needed is the use of facilities like Jericho House in Inverclyde, which is very successful in the rehabilitation of drug users. In order to utilise these facilities, Scottish Government needs to provide the finance to do that. Thank you.
Thank you, Jerry. I think your comments are noted there. Graham Brooks.
Thanks very much, Convener. At item 6 on the agenda at 4.2, I had some questions, but they've been generally covered by Elizabeth and the reporter. Just the fact that the 2 posts going from CLD or going to CLD is certainly welcomed. But and in the commentary, we've heard that the lines, in my opinion, CVS are crucial. I'd just be good in future to have that in the report, that the actual value of the third sector is crucial and part of this. But that was previously commented on, so it doesn't actually form a question, mainly my observation at 2.4. My question, Convener, if I may, and maybe Jerry's also picked up very slightly on it. Stephen said we have to think differently. We have to work out what is the intelligence in Scotland. I know Andrea has also said that obviously she's thinking far and wide. But I do know that nowhere in our reports, nowhere in even our Commission of External Organisations, does the Haven at Kilmacombe come into play. Now, I realise we don't fund them because we don't have MD from Inverclyde in there as a commissioned external organisation. But nevertheless, we have intelligence that we may or may not use, but we have intelligence on our doorstep. A 28-bed recovery programme, and recovery is a key word here, 28-bed residential unit, to a 44-week programme. And the cost, I can't believe how cheap it is. They annually spend 370,000. That's an average over the last 4 years. So from a Scottish government or even a local government point of view, that's a drop in the ocean. I don't know what the success rate is. I don't have that statistic, so I'm not going to comment on that. I've been told it's a high success rate, but that's information I don't have. But my question to officers is, do we speak to the Haven? Is there any way we can have intelligence from them? And we may even, thinking outside the box, choose to use a residential programme like the Haven.
Louise?
You can Louise, do you want me to take that question, or?
It's fine, you can take it and I'll add if we've got anything else to add.
Thanks. Sorry, I don't have my camera on, so I can't see. In response to the questions around residential rehab, I would like to advise committee that there is a piece of work going on with the Scottish Government at the moment reviewing residential rehab, and it is high up the Scottish Government's agenda. So I'm expecting some further work and some further information and actions to come out from that. I would like to reassure committee that we have used residential rehab and we will continue to use residential rehab as part of our assessment, our thorough assessment that we do through our alcohol and drug recovery service. As part of that assessment, particularly if somebody has been supported for a long period of time or has maybe come in and out of treatment, as part of that there is a discussion around whether residential rehab would be appropriate, and also what kind of residential rehab would be appropriate, because as I think members have pointed out, there's different organisations out there. We do have contact with all the organisations, and I do think it is something, as I say, with the Scottish Government report that will be higher up the agenda.
Right, thank you. Colin Jackson.
Thanks, Convener. Convener, for me, this report kind of fails to acknowledge that drug deaths' impact on working class communities like Inverclyde that have higher levels of poverty, unemployment, low pay chances than the more kind of affluent areas. I know that yourself, Convener. I mean, we're aware that in 2018 there was a report produced by academics from the University of West of Scotland titled Drugs and Alcohol Today. This report made it very clear that funding decisions by the Scottish Government to cut budgets were directly linked to the increase in drug deaths in poorer areas like Inverclyde, Glasgow and Dundee, which we've referred to. This report also claimed the Scottish Government ignored all evidence and continued to cut the budgets. In fact, when this report came out, the Scottish Government put out a statement where they refused to acknowledge the figures. But I think for myself, what really angers me, Convener, is that having seen all this evidence, how MSPs from communities most affected like Inverclyde, Glasgow and Dundee, continually support these cuts. I mean, when these figures were released, showing that Scotland again had the highest drug deaths in the Western world, I looked to Inverclyde MSP Stuart McMillan, asking why he continually, knowing the evidence, voted for these cuts. I asked him, in the light of the evidence, if he regrets his decision to support the cuts that have devastated so many lives in this community. And I've also asked him if he would like to apologise to those affected by his decisions to support these cuts. But, you know, unfortunately, everything for the Scottish Government, I've had no reply for him. But given the reluctance of the Scottish Government to accept they got it wrong, I suppose this goes in some way in answer to the question of how a small country like Scotland could have the worst drug crisis in the Western world. That's what I've kind of got to say, Convener. Thanks.
Thanks for them comments, Councillor Jackson. Elizabeth Robertson.
Thanks, Convener. Just a final question on this paper, if that's all right, and I'm going to be an insufferable broken record, I'm afraid, so bear with me on this one. Obviously, we've had the situation where we've talked at length at this committee about the police decision with regards to the naloxone use and the pilot that's been brought out. If you look at Section 2.3 of the covering report for this paper, then we can see that Dundee, Glasgow and Inverclyde are the three areas that are most heavily hit by the drugs deaths that have happened in Scotland. If you look at figure 4, which Andrea alluded to as well on page 8 of the report, we can see that really clear, just the extent of the issue in our three areas in comparison to other parts of the country. But when the decision was made to do the pilot with naloxone with Police Scotland, it was decided that it would be done in Glasgow North and Dundee and in Falkirk to get a geographic spread across the country. I just don't think that that's the right sort of basis to make that kind of decision. It should absolutely be made on the basis of need, where the biggest issues are, and trying to make the biggest impact that you can with the potential pilot. And I'm wondering if, and possibly again not for this committee, because as Louise has said, it's the ADP that govern this side of things, but if we can request that the ADP, given that we've just had a change in ministerial appointment and actually a new ministerial position put in place, Angela Constance, I believe, to be the minister for this particular area, if this is the time to actually go back and go, can we please revisit that decision? And not persist with the notion that Falkirk deserves that pilot more than Inverclyde does, because it absolutely does not.
Louise Long.
Through yourself, Convener. Councillor Robertson, as you know, I wrote to Police Scotland to ask them if we could be part of the pilot. Interestingly, I also wrote to the Scottish Government to ask them if we could be part of the pilot in relation to residential, so that whenever there is any pilots going in relation to alcohol and drugs where there may be funding or there's something in it, if we're really at the front asking if we can participate in it. I'm perfectly happy to write back to the or maybe the convener might want to write with some support from officers to the new minister, asking that they actively consider that. I think that would be that may be something you may wish to consider.
Councillor Rebecca.
Convener, I'm reading an article I'd seen a while ago and I got it up. Frontline police officers have been warned against using life-saving overdose kits on addicts over the fear they could be charged with assault. Police Scotland is developing proposals to issue officers with naloxone, a nasal spray which is used to treat victims of drug overdose for a trial period. This move comes after paramedics are to train families of heroin users on how to use the kits in soaring drug deaths related in Scotland. Now that was on, and it was the Federation that was on television, but that was actually a national newspaper. And I know, Louise, at the time we were trying to get it down here as a trial, and I just wonder what's going to happen. As I say, as we keep saying, for these things we've got to work together. How and what's happening? Surely, God, they can turn around and get some system that can be trained to do it and use it. If a person's taking an overdose and you can save their life by spraying whatever it is on them, then you do it. Because if he doesn't, you have no other option, or she had no other option. She's dead, isn't she? And I mean, I think that's something that should be spoken about. How can we work on this and get them to change their mind to make sure that we do this and can do it without being sued or without being taken to court? That should be part of it. They've done it to save their life, and surely that should be the main thing. And that's the way we should work it. What's your views, or what's Louise's views on that?
I don't know. Louise, you got a view on it? As we asked the Police Scotland for a view, I don't know.
I think the situation, through yourself, convener, I think the situation's changed, Councillor Rebecca, in the sense that police officers are now allowed to do that, and that's the idea of having the pilot. And I see in the commentary that Councillor McElhenney has said about Scottish Ambulance Service and the Scottish Ambulance Service in Inverclyde carry it. I'm perfectly happy, as I say, to go back, or if Councillor Moran, as the convener, wants to go back, I'm happy to support him. If the members think that that's a good idea and they want us to take that forward.
Aye. I think too, Louise, I mean, although we're talking about the police services, the Scottish Ambulance Service, I think we have members of the Health and Social Care Partnership staff who are trained in using naloxone, if I'm correct.
Yeah, we've trained our staff. We've also started training third sector. There's a whole range of people we've been training in relation to it.
That's good. Thank you. Councillor MacLeod, Jim.
Yes, thank you, convener. I think it's sad that we're still 2020, up till now, we're still seeing so many people dying from drugs and alcohol. It's terrible for them, their families, and their friends, and it's terrible that places like Inverclyde are worse than many other areas. But as we can see, and we have seen over the years, that there's a strong correlation between poverty, ill health, and also I think a sense of hopelessness amongst many in our population. And we've seen that in the paper, when it talks about Glasgow, Dundee and Inverclyde being amongst the worst areas there is in Scotland, and I would suggest in Europe. So it's a very sad situation. I think I've said to you before that 20 odd years ago I was involved with Inverclyde Forum about drugs as a community rep at the time, and we got a report compiled together which showed the extent of the drug problem in Inverclyde way back then. And there were local politicians at that time who didn't want that report to see the light of day because it would put the district in a bad image. But it did see the light of day, and it was on national TV, it was in the national newspapers, and we had a conference from it in the James Watt College, which I think Councillor McCabe and possibly Councillor Rebecca attended at that time. And a lot of good things did come out of it, and Inverclyde was given a lot more money, and some projects were started up to try and address some of the issues that existed at that time. But sadly, 20 years on, and you really must question, what has been achieved over that time. Sadly, we still see so many people involved in taking drugs and still drinking so much alcohol. And Councillor McCabe said it himself earlier on that there's been failures locally and nationally, and we have to have a new way of thinking, a radical way of thinking. Andrina spoke about many of the new things that are coming online. The naloxone's getting rolled out more. It's going to third sector. It's going amongst other agencies. Thankfully, the police are taking on as a pilot. Albeit God only knows why they hadn't taken on before now. As Elizabeth says, it's sad that Inverclyde wasn't one of those areas. And there are other treatments coming online as well, which will hopefully help in the future. But, it does need radical thinking. I have to say, though, the Scottish Government, in fairness, have come out with some ideas about taking the criminality out of drugs and not making drug offenders criminals. and also about safe treatment rooms, which we'd like to see in Scotland. That just been two of the things. But sadly, because many of these powers remain reserved at Westminster, we aren't able to implement those things. So I think until we can really be able to do some things our own way in Scotland, it will still continue to be a struggle. What I would like to ask, I do have a question though for Andrina, because I saw that obviously it mentions about methadone and gabapentin. It talks about the vast majority of people who have sadly died from drug overdose. It's been more than one drug. It mentions a number of other drugs that have been involved, and it did mention that methadone and gabapentin as being two of those drugs. Now, as we all know, methadone and gabapentin are prescribed drugs as well. So what is happening there to try and safeguard? Is there tests going on regarding people who are both on methadone and gabapentin to check that they're not still taking other forms of drugs?
Through you, Convener.
Yes, Andrea.
I think one of the things we are aware, and in terms of the medication-assisted treatment work that we are doing, as well as introducing new treatments, we need to look at making sure that people are on appropriate treatments. And as much as a number of people don't particularly like the use of methadone, it is an effective and appropriate treatment, and it's given at the right doses. And what we find is that a number of people don't want to be on higher doses of methadone. And what happens is they effectively use other drugs to what we would class as topping up. So one of the things that we need to work on is making sure that people are on the right doses of treatment and the right doses particularly of methadone to get them stabilised and get them supported.
Thank you, Andrea.
Yeah, but can I just ask again? Are any checks done, and to try and to try and see to better help support that? Because I mean I've heard this over a number of years now that that other drugs are taken in top of methadone as a top up. But if we know, and we've been aware of this for some years now, that this occurs, so what more are we doing to try and encourage that not to happen? And are any tests carried out, to blood tests or whatever else to check on if there's any other drug taken?
Through you, Convener, there are things like, for example, urine tests that can be taken, which will indicate whether people have got certain drugs in their system. Part of the issue is that some of the street drugs now are so sophisticated that they look so similar to the prescribed drugs. It's sometimes quite difficult to actually be able to identify whether they are actual prescribed drugs or street drugs. And as we know, a number of people are on prescribed medication or are able to obtain other people's prescribed medication. So it's a really complex and difficult area.
Yeah, I know there's no easy answers to it. Does anyone else want to make a contribution to these very important items? Lynn Quinn. Lynn?
Yeah, thanks, Robert. Yeah, just to quickly, just under agenda item 6, under the prevention part, I'm just trying to explore, is there been a conversation with our GP practices? I mean, obviously it's been mentioned about prescription drugs, but obviously we've got, and we're not talking about severe mental health, but people presenting their GP with mental health problems are for pain relief, and they're potentially prescribed medications that lead down a path. Is there any discussion around alternative prescriptions rather than these obviously addictive medication being prescribed?
I'm happy to take that question, Convener.
Yeah, it's on you go, Andrea.
Okay, thank you. Councillor Quinn, there's currently a pilot being funded through the Alcohol and Drug Partnership, where we have a pharmacist working with some of our GP practices reviewing people's pain medication, because we are aware, for example, benzodiazepines prescribed are very, very effective on a short-term basis. And then if somebody, they can become addictive if you're on them for a longer period of time. So that piece of work is currently being piloted, and we have a pharmacist in doing that work at the moment.
All right, Lynn. Councillor Quinn, you quite happy with that? Councillor McCabe.
Thanks, convener. I'll avoid getting drawn into the debate about whether we've got enough powers in Scotland or not, given we've actually got higher drug deaths than the rest of the United Kingdom. But that's a political debate that I'll avoid. No, I just wanted to, and I see Councillor Brooks has put something in the chat. I just want to sort of formalise that we should, on the back of what Councillor Robertson says and the corporate director, I think you should, convener, I think it would be entirely appropriate, you should write to the new minister around the two pilots and ask if Inverclyde could be included in those pilots.
Thank you. Anybody else? Okay, we have a couple of proposals from Councillor McCabe. We have an all-members briefing on the drug review paper, and we can get an all-members briefing too, if that's agreed. And also, I write to the minister, ask him to review the pilot for the naloxone. Is that agreed?
Agreed.
Right. Thank you for that.
Come in
and you chair it.
Sorry.
And you chair it, remember. That's what Councillor McCabe said earlier on. You chair the meeting, so remember.
I was able to go, Chara. Louise, you want to say something?
Yeah, it was just to ask members if they could be a wee bit patient in relation to the all members briefing, given how busy the partnership staff are at the moment. If we could wait until we come out of this lockdown situation, that would be extremely helpful.
Convener, I think that's absolutely entirely appropriate. We had a lengthy discussion at the Policy and Resources Committee today about the pressures on staff, so absolutely understand those pressures. So absolutely, it's only when circumstances allow that we can have that briefing.
Yeah, I think that's fair.
Thanks very much.
Robert.
Yes, Jerry.
See, as well as writing to the Minister, would it be appropriate that you write to the Chief Constable and ask him to trial the naloxone down here with the police officers?
Well, I don't know. I think they're actually advised by the Scottish Government where the pilots would take place, Jerry. I don't think it might be. I don't think it's appropriate as to approach the Chief Constable, because I think he has to adhere to what is coming from the government. But maybe Louise can help me in that one. What do you think?
Through yourself, convener. Thanks, Councillor Donovan. That's a good idea. We'll maybe CC the constable into the letter that we put to the minister. If that's okay.
Good. That's fine.
Convener, just to be clear, I think we were talking about the two pilots. I think the corporate director had suggested the other pilot around. She'll remind me what it was again.
Residential rehab.
Residential. So I think it would be the two pilots.
Aye. It's a very complex matter, you know, and as you say, it's a real tragedy. So if we can work together on it, as Councillor Bright says, we hopefully we can come up with some sort of solution. It'll not be overnight, obviously, but if we work together, we might be able to achieve something. Right. Thank you, everyone, for that. So after that lengthy discussion, we have a quick item, I think. Sharon, the Child Sexual Exploitation Research Report from Barnardo's, October 2020. Sharon.
Thank you very much, convener. So the report that has been presented here covers some of the material that was covered in terms of the Barnardo's and Scottish Reporters Administration. in respect of child sexual exploitation, and particularly how Inverclyde is responding and dealing with this complex area of child abuse. I maybe want to start my input in relation to the report by highlighting paragraph 2.2, and just to underline what that section of the report is saying, is that even within the context of child protection and child abuse, child sexual exploitation brings an added layer and depth of complexity to that whole topic. But as well as that, an important thing to highlight is that, particularly with child sexual abuse, it's seldom a dimension of protection in and of itself, and that very often when it occurs, it is very likely to occur when there are predisposing factors, where there is existing child protection issues, concerns, vulnerabilities around for children. So that adds to a complex situation within a complex situation, but I know that members understand that. And the other area I think is important to highlight is in 2.5, which is the strategic response. Section 2.5 really encapsulates our strategy and how we respond to child sexual exploitation. There are 3 parts to that strategy, and it is important again to stress that this is a multi-agency, multidisciplinary response, coordinated through the Child Protection Committee in Inverclyde, which I'm currently chair of, and that we have a child sexual exploitation working group that looks specifically at some of the work and activity and actions that we need to progress as we tackle this area of child abuse. And while it's not a new phenomenon, it's been with us forever, it has a different profile, and we're learning more through research about it more and more. I'm sure some members will recollect that the current chair of the National Child Abuse Inquiry in England, Professor Jay, used to do the job that I do right now here in Inverclyde. She was at Strathclyde Regional Council, but it's the same job that I'm doing currently, and she chairs that National Child Abuse Inquiry south of the border, and also led on some really pretty important inquiry work in relation to this area of child sexual abuse. So all of that is helping our understanding as we develop our responses to this area. But in particular, the areas of activity that we are concerned about are in relation to prevention and early intervention, disruption, intervention, recovery, disruption and prosecution. So that's the 3 strands that we focus our activity around. There's a definition which is included, and I think, again, just to highlight the complexity, it's taken a number of years for us to agree what a definition of child sexual exploitation might be. Of course, locally, we need to take that definition and apply it within our own circumstances. The report outlines a whole range of activity that is taking place under those different strategic headings. Social work services take the lead around the intervention and recovery elements of that. That's the area that social work services have got a lead professional role in partnership with colleagues in terms of the intervention, but certainly in terms of the intervention and recovery, that's a core remit for social work services. The work that is outlined in the report is fairly detailed and fairly deep, and it covers a fair degree of breadth. But I wanted to highlight 4.11, which is work that has shown great promise that we've been developing here in Inverclyde, and is work that is wholly aligned again with our approach to the UNCRC, and that pandemic dependent, we would hope that this work will issue in 2021, and we check this work with Scottish Government as we go, and they are interested in, at very minimum, using this as a basis of work that they might then want to develop that might have a national rollout, and is based on what support that we've had from Barnardo's over a number of years. There's some data in the report, and much like Andrina had mentioned earlier, I think it's really important to note data small numbers, because we're doing a comparison between a 3-year trend analysis for Inverclyde relative to the Barnardo's report. And you'll note there that the numbers are small. It's also really vital to note that when we're talking about child sexual exploitation, we're not talking about a given event. We're talking about a range of activity, and we're talking about circumstances for children who have been, who are suspected to be, or who may be at risk of child sexual exploitation. So all of that is considered within the data that's contained within the report. I'd maybe want to just say a word about the use of secure care in this context. It is not a preferred option or response to use secure care for children in these circumstances. Sometimes it is a place of last resort that we have to use, but it's a place that our preference would be to avoid as far as we're able to do that. And increasingly our activity in terms of that intervention recovery is looking at how we can develop nuanced, sophisticated resources that protects children and helps them and prevents further occurrence of harm to them in a way that avoids the use of restricting the liberty, because essentially these children are victims. I'm happy to take any questions.
Thank you much, Sharon. I have two people come in. The first one's Colin and then Elizabeth. Colin. You're on mute.
Right, can you hear me, Robert? Hi.
Yes, can now.
Right, thanks, Convener. As you know, Convener, I've raised the issue of the Barnardo's report previously. In my read I was quite shocked. So I asked how many children in Inverclyde were identified in the report of being at risk of being sexually exploited. So I very much welcome this report from Sharon, and to say personally, as far as young children are concerned, I feel reassured that this council, through early intervention and prevention, are taking every step possible to keep our most vulnerable children safe from exploitation. My only concern is that of young adults through, online exploitation. So I'm maybe hoping at some point in the future we can maybe get a report on how we protect young adults from exploitation. I know it's a different report, and it's not to do with the Barnardo's report, but I'm just hoping maybe we can do future work on the protection of young adults as well. But just to say, I welcome Sharon's report, and I find the work that the council are doing is very much welcome. So thanks, Convener.
Thank Sharon, you think we could do that report? Will you get things quiet down?
Yeah, I'm very grateful for Councillor Jackson's comments, and I'd be keen to bring anything to committee that I can find that we're working in quite a different legal context when we're working with older young people, but I can outline the work that we do, and I can look to see what else it might be around that we can bring that would provide some context to that. And I need to say I really welcome the opportunity to raise some of these issues. I'll highlight, I mentioned earlier Professor Jay's comments and one of her findings, and I've brought a report about this to committee previously, that one of her findings previously in other areas, and I don't think it was specifically Rotherham, but areas of that nature. And one of her findings were that people like myself weren't subject to sufficient scrutiny through their elected members. And I really welcome the opportunity to be put through my paces in terms of the work we're doing in relation to these young people. So I'm happy to bring forward work that we can provide reassurance to members.
Thanks very much for that, Sharon. Elizabeth Robertson.
Thanks very much, Convener. I'm taking a wee trip down memory lane in a way with this one, because I was involved in the delivery of the training, and I have to say I've delivered many training courses in many contexts in the course of my very long now life. But it was an absolute privilege to deliver this one, because I have never seen training be more powerfully received by the people who've sat under it. And actually having people sit and see that they are the eyes and ears in the community for any change, and is the things that can give you an idea that somebody is being sexually exploited for one young person could be the very opposite of the thing that lets you think that somebody else is being sexually exploited. And it's just looking at the changes that we see in our young people, and actually being the eyes and ears to be able to do something about that. And I've never ever seen people sit under training and actually have such collective and strong light bulb moments, that actually having this on your radar when you're working with young people in any capacity, just having it there as this young person at risk, because I guess absolutely there's kids who are more vulnerable, but one of the strong messages of the training, certainly when I was doing it, was that any young person is vulnerable to child sexual exploitation. There's clear vulnerabilities, but the profile is there. And actually, honestly, I'm thinking back to particular instances that we had where really it was such powerful training to deliver, and a real privilege in my career. I think it's fantastic that we've got a young people resource, because I think it's really important that our young people are eyes and ears for each other and have as much information about what sexual exploitation looks at, because the key thing is that a lot of young people, you're right, don't acknowledge that they are in fact victims, because it doesn't look that way to them. That's not how it looks. But when I was looking at section 4.8 and the list of people who've undergone training or who've had access to training, there was a key group that I felt was still missing, and that's parents. And I'm wondering if there is any plan, and again, I know we're in a particularly weird period of human history, but if there's any plans to do work with parents, who are yet another huge group of eyes and ears within the community, to protect young people from something that is a very, very tricky thing to see.
Sharon?
Yeah, absolutely, and it's definitely something that we'll keep trying to engage with. We did have a go, and I don't know if you remember, Councillor Robertson, we tried to open this up through schools, and it wasn't something that was particularly well. In fact, it was the attendance was not good. So we need to be more creative, I think, in how we do that. You'll know that we focus in on those parents where we know the vulnerability exists. But that's much more that one-to-one conversation, and it misses that early intervention and identification part. So it's usually once we're already in a situation where harm is either happening or likely to happen. So yeah, it is an area that we are keen to continue to look for creative ways to engage. And I do think that some of the work we're planning around the promise might provide us with that, because I think we are rethinking our entire strategy about how we engage with parents, and needing to be creative on the whole, because I think we are very good at that work with young people. We need to be better at how we do it with closing the circle with the adults that are in children's lives.
Right. Any other member got a comment to make? Oh. Sharon, can I just say, when you get these reports, they're sometimes very technical for the ordinary members, but I think at the appendix with Sam's story attached to it really brings it home exactly the work that you do. And probably like myself, who are old panel members, have done plenty of training with such stories, but it really does give the members a real understanding of the work that's going on. And I think that's a fantastic thing, to attach that appendix with Sam's story, and it really gives you a real insight into some of the work that's going on. So thank you very much for that.
Thanks, Convener. The other thing I maybe should stress is that's a composite case study. That's not a young person. That's not a...
Yeah, I know. Craig Capstick rings a bell.
Thanks, Convener.
Right, we agree with the proposals on Sharon's report there, and that takes us on to the last item, which is item 9, is report exception of governance of HCP commissioned external organisations. And it's got Louise's name beside it, so I don't know if you're going to speak to it or one of your officers.
Convener, could I just confirm that this is a private item, but the press have already left?
Oh yes, sorry Sharon.
Thank you. Thanks.
It's been a long day. We're now in the private section, so members of the public, please leave